Today's lecture is going to cover burns. We're going to talk about the anesthesia management of patients with burns, how to calculate fluids appropriately, and some of the pathophysiological changes you'll see in burn patients. For this lecture to be most effective, please review your oxygen dissociation curve. Regardless of the type of injury, we want to be able to classify them, and this is done based on the depth and extent of tissue destruction, as well as the total body surface area involved. The first degree or superficial burns are usually limited to the epidermis, and the epidermis itself is thin and avascular. Usually healing occurs spontaneously. Second degree burns are also known as deep and superficial partial thickness burns, and these extend onto the dermis. This area is very vascular and contains lots of nerves, and the severity of this type of burn varies depending on the amount of tissue involved. Third degree burns or full thickness burns extend to the subacute tissue lying below the dermis. Skin grafting is usually required with this type of burn. You may also see the classification of fourth degree burns, and that is used to describe those that burn below the dermis, such as muscle, the fascia, or bone. This is a good summary slide, and this slide talks about the difference between the first, second, and third and fourth degree burns. It talks about what the outcome and treatment should be. I would review this slide. And this also just shows, this picture is just showing you the difference between and what area of the tissue could possibly be involved. The rule of nines is a way to quantify by estimation the amount of the body surface area that is burned. In this, the body is divided up into represent 9 or multiples of 9 related to the total body surface area. Specific modifications are applied to children because the surface area of their heads and trunks are proportionally larger than their extremities. The Lund-Brauer chart provides a more specific way to quantify, and there is a figure in your text that demonstrates this method, and it is probably more accurate in determining the amount of area that is burnt. This is the chart that shows you the rule of nines, and yes, you will probably be asked a question on your exam related to this. This slide shows you the Lund-Brauer chart. Be familiar with both charts because you never know what will show up on C examinations or on your comprehensive examinations. This is a direct quote from the Nagelhout text, the 5th edition, and it describes what is a major burn. And a major burn can be a second-degree burn involving more than 10% of the total body surface area in adults, or 20% at extremes of age, or a third-degree burn involving more than 10% of the total body surface area in adults, any electrical burn, or any burn complicated by smoke inhalation. There's also a mortality formula that is derived by the National Burn Registry, and it is if the patient's age plus the percentage body surface area exceeds 115, then the mortality of that victim will be greater than 80%. There are 4 types of burn injuries, and that is chemical, electrical, thermal or heat, and this can also be referred to as flame or scald injuries, and inhalation. Chemical burns generally occur in a laboratory setting, and once the substance is on the skin or the chemical is on the skin issue or the disruption will continue until the irritant is removed or neutralized. So the initial treatment for this type of injury is to apply copious amounts of water or normal saline irrigation. Electrical burns can not only damage the skin but also the surrounding tissue. Sometimes there is significant tissue disruption at the points where the electrical current is most concentrated, and that's usually the entry and exit wounds, although these wounds may not completely be evident in all cases. Burns this way, electrical burns can severely damage bones, blood vessels, muscles, and nerves. And as you would suspect, there can be a release of myoglobin, which puts the patient at risk for developing renal failure. Thermal burns or heat burns, approximately 70% of burns sustained by those of 4 years of age are a result of scald injuries, whereas flame burns are most common in children who are 5 years of age or older. Inhalation injuries accompany thermal burns and should be suspected until you rule them out. So anytime you see a burn, you should try to rule out, do they have any associated inhalational injury as well. The first type includes the upper airway injuries, and that's caused primarily by thermal injury in the mouth, oropharynx, or larynx. The second type would be the lower areas, which would be the lower airway and the parenchyma, and that can be caused by chemical or particulate portions of the smoke. And the third would be by metabolic asphyxiation, when certain smokes or certain fires will contain cyanide or carbon monoxide. And it's important to note that any three of those can be present at any time. Damage to the airway can vary based on the type of burn and what part of the airway is affected. Again, like we said, damage to the airway, you should suspect it until you rule it out. Thermal injury, again, like we said, was the mouth, oropharynx, larynx, and then we could have the lower airways and parenchyma that are damaged, and that's generally by chemicals or components of the smoke itself. We talked about metabolic asphyxiation. Again, brief exposure to either excessively dry heat or steam that's 100 degrees Celsius can cause massive edema and airway obstruction. Again, the addition of inhalation injury to a cutaneous burn doubles the mortality rate. Again, obstruction of the upper airway can be due to edema, macroglossia, or swelling of the pharyngeal soft tissue. And like we said before, swelling in the lower airways would generally arise from inhalation of particles or chemicals that are released from the fire. Signs of impending issue or warning signs of respiratory injury include hoarseness, sore throat, dysphagia, hemoptysis, tachypnea, use of accessory muscles, as well as elevated carbon monoxide levels. Treatment of burns revolve three stages, as 3 phases: the resuscitative phase, debridement and grafting, as well as the reconstruction phase. And each one of these provides different challenges and a different set of skills for the anesthetist. Again, treatment of the burn would be following your standard ABCs, your airway, breathing, circulation, as well as looking for coexisting traumas. And remember, all burns patients must be considered at risk for pulmonary compromise, especially if we have a large percentage of total body surface area that has been involved, or signs of inhalation injury are also present. A history and exam, again, it's important to rule out airway injury, especially in those patients who are at risk. A diagnosis should be made through the history, the circumstances surrounding the burn injury, as well as through your physical examination. Remember, we could have occlusion of the airway, and it isn't to be noted that heat will rarely cause damage below the vocal cords, just the heat itself. It is important to provide a proper airway examination, and this should be done through direct visualization, and that can be done with a laryngoscope or with fiber optic bronchoscopy, and this would be the gold standard. Again, the picture on the right side is showing you a burn patient 4 days post-burn, and you can see the swelling and the bleeding. But chest x-ray can be done, but it's usually normal in the early phase unless the patient has aspirated or there's pharyngeal contents that occurred as part of the accident or part of the burn process. It will become abnormal once pulmonary edema or infiltration develops. One of the standard treatments or things you should do early in the burn is to provide intubation, and this can be done even prior to any respiratory decompensation occurring, especially in burns that are a large area, and that is even in the absence of inhalation or the suspected inhalation injury. This intubation can be difficult because if there is swelling that occurs, this can cause malalignment of our tissues, and bleeding can also be involved, which can make visualization difficult. In the pediatric population, if you're using an uncuffed tube, which generally occurs, you would use one size smaller than expected according to the age and weight. If you provide nasal intubation, generally for the pediatric population, this is better tolerated, and tube placement or displacement with movement is less likely. Also with this, you can use a cuff tube, and this decreases the risk or the need for replacement once the edema starts subsiding because of the air leak that occurs. In the absence of any airway abnormality, you can do your early intubation using a rapid sequence technique. You can use succinylcholine within the first 24 hours of the burn. However, after that, it's considered unsafe, and that is due to the proliferation of the acetylcholine receptors that can result in hyperkalemia. Again, proliferation of those acetylcholine receptors results in hyperkalemia. It is best to avoid 24 hours post-burn. Non-depolarizers in burn patients, you can generally have resistance, and this is because the upregulation of the acetylcholine receptors and the massive fluid shifts that produce changes in the volume and distribution. Again, abnormal airway or upper airway obstruction, the safest way to secure the airway in this case would be an awake intubation. Again, you want topical anesthesia, you want good patient positioning and supplemental oxygenation. You can use incremental doses of ketamine or dexmedetomidine along with your topical anesthesia, and this helps to avoid the reflexes and allows the patient to continue to have spontaneous breathing. Again, usually other sedatives are avoided because of the risk of worsening the obstruction, but you can provide a little IV opioid, again, especially in an alert patient who's in a lot of pain. When the upper airway is badly damaged and you are not able to intubate, you may be required a direct surgical approach such as a tracheostomy. The burn patient should be taken to the intensive care unit. Their inspired gases should be humidified, and that helps to clear the debris and prevent drying. Also, administration of nebulized heparin and N-acetylcysteine with massive burns and smoke inhalation may result in decrease the incidence of reintubation for progressive pulmonary failure, decrease atelectasis, and also to reduce mortality. Any burn victim that was found in an enclosed space should be considered at high risk for carbon monoxide poisoning. The symptoms themselves depend on the carboxyhemoglobin level. Remember that carbon monoxide has an affinity, according to your nasal health text, 200 times greater than that of oxygen. However, other resources will say up to 250 times greater. And Basically what happens, there's greater affinity than the oxygen, leading to a fall in your oxyhemoglobin saturation, so the tissues become unable to extract oxygen. The end product there would be metabolic acidosis at the cellular level, because you no longer have the oxygen available to go through the electron transport chain. The analysis of blood gas would probably reveal a normal arterial oxygen tension, but a decreased total oxygen content level. Carbon monoxide also increases the stability of the oxyhemoglobin molecule, so there is a decreased release of your oxygen to your tissues, which results in a leftward shift of your oxygen dissociation curve. Pulse ox, remember, cannot detect this. They do not detect carboxyhemoglobin. And the half-life of your carboxyhemoglobin is variable. And different texts will say different things, but your NAGLE Help text says 26 to 148 minutes. And treatment continues with 100% O2 until the carboxyhemoglobin level is less than 5%, or for 6 hours. You also can see the use of hyperbaric therapy, and it may be helpful if that level exceeds 25% or if there's clinical signs of toxicity present. Hydrogen cyanide is a poison that can be produced by the combustion of materials such as plastics, foam, paints, wool, and silk. And it produces tissue hypoxia because it blocks the intracellular use of oxygen. And this occurs when cyanide binds to the terminal cytochrome on the electron transport chain. And this results in lactic acidosis as well as an elevation in the mixed venous oxygen saturation. The half-life of hydrogen cyanide is approximately an hour. Signs and symptoms of poisoning include loss of consciousness, dilated pupils, seizures, hypotension, tachypnea, apnea, or high lactate levels. Vitamin B12, the active form, is hydrocobalamine, and it actively binds to cyanide by forming cyanocobalamin, which is directly excreted via the kidneys. The hydroxycobalamin has rapid onset and a very good safety profile, and a dose of 50 milligrams per kilo is recommended. After the airway has been secured and you've treated your other injuries or life-threatening injuries, the patient requires resuscitation with large volumes of fluid. They basically have loss of circulating volume, and so burns result in a form of hypovolemic shock. So they will have loss of circulating plasma volume, hemoconcentration, massive edema formation, decrease in their urinary output, and depression of their cardiovascular function. The fluid losses are greatest in the first 12 hours after the burn, and they generally begin to stabilize at 24 hours. Again, fluid loss can be direct due to plasma and the plasma proteins diffusing from the capillary beds. We also have capillary leak results from loss of endothelial integrity and from reduction of the intravascular onconic pressure resulting from the loss of those plasma proteins. Again, this would be clinically manifested by hypovolemia as well as burn-induced edema. Most edema is locally at the burn site and usually is maximal at 24 hours after injury. The edema itself can cause tissue hypoxia and increased tissue pressure with circumferential injury. Again, aggressive fluid therapy can correct the hypovolemia, but will also cause an increase in the edema process itself. Within seconds of a burn injury, the massive fluid shifts have already begun. So it's very important to start initiating the fluid resuscitation to help to provide the best outcome. There are multiple formulas used. Regardless of the formula, they usually contain the patient's weight in kilograms as well as the percentage of total body surface area involved. The two I want you to be familiar with for this examination would be the Parkland as well as the modified Brook, and those are listed there, to the side in that figure. The Parkland is 4 mLs times the body surface area percent times by the weight in kilograms. And you generally give the first half in within the first 8 hours and the other half over the next 16, which would be divided into 1/4 over the next 8 hours and 1/4 over the final 8 hours. The modified Brook uses 2 mLs times the total body surface area of the burn times kilograms, the weight in kilograms. So be familiar with those. Usually blood replacement is not a major concern unless there are other issues going on or other traumas that are coexisting in that patient. Following a thermal injury, transfusion is usually not needed until the hematocrit would be 15 to 20% in a healthy patient that's having a limited operation, 25% if the patient is healthy but having to have an extensive surgery, and 30% would probably be the lowest tolerated level in a patient who is presenting with a pre-existing cardiovascular issue. Again, these formulas are advocating the use of crystalloid. Colloid solutions are not advocated in the first 24 hours due to the capillary permeability remains enhanced, and colloids will not remain in the endovascular space. Again, crystalloids generally provide adequate volume hydration, but remember large volumes that are needed could result in increasing the tissue edema as well as the hypoproteinemia. Consequences of complications of overhydration include abdominal compartment syndrome, pulmonary effusions, pulmonary edema, and conversion of a partial thickness lesion to a full thickness lesion, and those are very frequently observed. Again, like mentioned before, the complications, be familiar with complications of overhydration, and resuscitation should be based on the patient's response to the fluid resuscitation, and that can be the hemodynamic stability of the patient, the level of sensorium, and the urinary output, and it's generally 0.5 to 1 ml in adults and 1 ml per kilogram per hour in children weighing less than 60 pounds. And that's important instead of just relying on a fixed formula for your fluid needs. There is recommendation that to counteract the rapid use of glycogen stores and to prevent the development of hypoglycemia, you should use a dextrose-containing IV solution in children who are burned, and this should be in the immediate post-burn period. Again, it's important to know what the minimum amount of urinary output that is needed in adults versus children. So familiarize yourself with this table. Some of the criteria to determine that you've had adequate fluid resuscitation include normalization of your blood pressure, urinary output at the appropriate level. Use the table from the previous slide to determine what that is. Blood lactate level of less than 2 millimoles per liter. Basic excess or deficit less than -5. Gastric intermucosal pH greater than 7.32. Your central venous pressure, your cardiac index, as well as your oxygen delivery index. If your hematocrit increases during day 1, this could indicate inadequate fluid resuscitation because initially, because of hemolysis and sequestering, you would think that this parameter should be decreased. So also if you have a pulmonary artery catheter in place, you want to check for adequate cardiac output, adequate filling pressures, and a mixed venous oxygen level of 35 to 45. Pathophysiological changes are important to know following a burn. Again, following the burn, the patient will be in hypermetabolic, hemodynamic phase, especially if the patient has had greater than 40% of total body surface area involved in the burn. And this pronounced hypermetabolic response can persist from 1 to 2 years. And during this phase, you can see increases in your metabolic rate, multi-organ dysfunction, protein breakdown, blunted growth, insulin resistant, and also increased risk of infection. 6 signs that are present: hyperthermia, catabolism, increased oxygen consumption, increased respiratory rate, increased heart rate, and increased serum catecholamine levels. Again, the burn patients have an increased resting energy expenditure, increased cardiac work, increased myocardial oxygen consumption, and they can have very marked tachycardia. They can have liver dysfunction, they can have muscle catabolism, again, growth retardation, all those things we mentioned before. Cardiovascular changes, remember the loss of the plasma proteins within an intravascular compartment can persist for up to 36 hours after the initial burn. Again, so we may see burn shock be present, and within the first 24 to 38 hours following an acute burn, or of an acute burn, sorry, not following, but of an acute burn. A reduction in cardiac output is a hallmark of burn shock and appears to occur within minutes of the injury. It initially is preserved based on your compensatory catecholamine responses, and we can also, coronary blood flow related to this catecholamine response can be reduced, which can further decrease myocardial function, and also we would have the SVR increase as well. Children with extensive burns can be hypertensive for weeks following their injury. They can also, their heart rate, cardiac output, cardiac index can remain significantly increased for up to 2 years following the burn. Pulmonary system, we can have pulmonary function can decrease even in the absence of an inhalation injury. Again, we can have the FRC be reduced and lung and chest wall compliance decreased, especially when the chest wall is burnt in a circumferential fashion. We can also have pulmonary edema, and that can be a result of the release of mediators in the lung, which can increase capillary permeability. Mechanical ventilation is often required, especially in patients who have had inhalation injury. The term acute lung injury is used when we have impaired oxygen exchange that results from lung injury, and the condition is characterized by a PaO2 ratio to FiO2 of less than 300. Anesthesia considerations related to the pulmonary issues: we want to use low volume lung protective ventilation, and this involves using tidal volumes of less than 7 mL per kilogram of ideal body weight and plateau pressures of less than 31. We can also allow for a modest permissive hypercapnia to occur. Other changes that occur, we can, the immune system, again, the patients are at higher risk for infection because they have white blood cell activity is depressed. If they are colonized for a gram-negative bacteria, it increases the risk of mortality. Renal function, they're at risk for acute kidney injury, and that results from the protein breakdown that can be present in urine as well as the hemoglobinuria. We can also have decreases in renal blood flow, which alter your glomerular filtration rate. Again, hourly urinary output measurements remain the gold standard for assessing adequate fluid replacement and resuscitation. GI system, there's important for aggressive nutritional support. Remember, these patients are in a very hyperdynamic state. Again, carbohydrate is more effective than fat in maintaining body protein levels. Enteral feedings, again, preoperative NPO guidelines must be considered at a safe minimum to prevent the patient from reverting to a catabolic state, so it's very important to think about your NPO status. Again, intubated patients do not require enteral feeding discontinuation before surgery, whereas the unintubated patient may require nutritional support up to 4 hours before your scheduled procedure. So it's important to look at that. Again, admission to the OR, non-intubated patients, NG tubes should be suctioned, and general anesthesia should be induced with rapid sequence to protect the airway. If the patient is not receiving enteral feedings but parenteral feedings through the central venous catheter, these should be continued throughout the perioperative period. Again, monitoring glucose levels in patients is advised. These patients are at risk for ulcerations of gastric and duodenal mucosa, and these are known as curling ulcers. Treatment here would be the use of supportive therapy, so acid suppression therapy, H2 blockers, and proton pump inhibitors, and antacid. Intra-abdominal hypertension and abdominal compartment syndrome are increasingly recognized as issues that cause significant mortality and morbidity in a critical care burn patient. These are the most dangerous and frequently reported adverse outcomes of fluid creep in following massive fluid resuscitation. Intra-abdominal hypertension is a continuum of progressively worsening organ dysfunction, whereas your abdominal compartment syndrome is basically an all or none phenomenon resulting when the intra-abdominal pressure is elevated and is not treated, may be unrecognized or not treated. These have impact on end-organ function within not only the abdominal cavity but also areas throughout the body. The guidelines define intra-abdominal hypertension as an abdominal pressure obtained by a transduction bladder pressure greater than or equal to 12 millimeters mercury, and the acute or abdominal compartment syndrome is defined as a pressure greater than 20 millimeters mercury with evidence of new organ dysfunction. Abdominal compartment syndrome is fatal without treatment, and treatment includes the use of neuromuscular relaxants and increased sedation in those who are mechanically ventilated. Also, patients with extensive burns on the anterior of the trunk may have to have that area have an escherectomy, and judicious use of diuretics as well as decompressive laparotomy. During the debridement and grafting phase, the goal is to restore your tissue integrity. Again, because most patients with extensive burns will require multiple procedures, it is generally limiting a single procedure to 20% of the body surface area is suggested. Again, other surgical endpoints include a time of 2 to 3 hours if the patient's core temperature decreases to 35 degrees Celsius, or if there has been blood loss requiring 10 or more units of packed RBCs. When you're working on an anesthetic plan for a patient who has had a burn, it's important to have a thorough pre-op plan, and again, it must be evaluated with your entire burn team. The pre-op evaluation, again, requires a thorough and complete assessment. You want your history, you want your laboratory studies, You want to provide lung auscultation and assessment of chest compliance. You should inspect the oral and cavity as well as the neck to determine potential difficulties in airway management. In addition, you should be aware that there could be underlying trauma and issues related to the burn, as well as the percentage of total body surface area that is injured, and the type and extent of the planned procedure. Again, you can see a table here talks about having a warm operating room ahead of time. These patients lose heat very rapidly, so it's important to have a warm OR. It's also important to measure the temperature appropriately, and this can be obtained by a properly positioned esophageal stethoscope. If you don't know where that should be placed, I started to say it to you, but please look at that. Where should it be placed to read appropriately? Again, many of these patients will require an intensive care unit, so they may benefit from a urinary drainage catheter that will support bladder temperature monitoring as well. Remember, you want to check availability of blood products and order more if they're needed, and that can be based on your preoperative hemoglobin value, the size of the burn, again, or the extent of the planned debridement. Have them available in the operating room as the debridement is initiated, and this is very important, especially for your pediatric patients. Have at least one blood warmer prime plugged in and turned on. If the burn is large, you may want to have two. Make sure you have adequate IV access before your surgeon begins. Have adequate supply of narcotics and muscle relaxants. Again, know ahead of time and plan if you need to use invasive lines. Plan for airway management and ventilation both intra and post-operatively. And have a plan, but be willing to modify as necessary. Again, some perioperative challenges or some issues are seen in the table to your left. But when you're taking care of your patient, know that your standard monitors still need to be used, but they can be hard to place. Remember, your EKGs are often difficult because of the lack of intact skin. You may have to have alternatives such as stapling electrodes or arterial pacing type esophageal stethoscope to be able to monitor your ECG appropriately. Blood pressure cuffs, again, should be on the non-affected or non-surgical site. If needed, like if you don't have a place, or if it's warranted, you can use a placement of a invasive line. You may have to be creative with your sites for your pulse oximeters, such as you may need to use the nose, septum, cheek, tongue, toes, and as we said before, temperature is important to monitor as well. So how do these patients lose heat? Why do they lose heat? They're in a hypermetabolic state, they have evaporative loss, and they also have fluid loss, and they have exposure. Steps to decrease this would be warm OR, humidified moisture exchanger, using lower gas flows, and that will help to decrease the evaporation that is lost through the respiratory tract, as well as warmed IV fluids. Just a sidebar or something important to know, most of their fluid or most of their heat loss is through evaporation, and you can lose 580 calories per each gram of water that is evaporated from the patient. Again, blood loss and fluid replacement. Blood loss is greater from Eschar removal. Suggests stopping for the procedure after 2 hours if more than 2 volumes have been replaced or have been lost, or if the temperature falls below 35 degrees Celsius or by 1.5 degrees from the baseline. Again, extent of blood loss, there are several formulas that are involved. Again, vary from 200 to 400 mLs for each 1% of body surface area that is excised and grafted, to as high as 4 to 15% of blood volume for each percent that is debrided. Preoperative anemia is another indicator for transfusion and is commonly seen in our burn patients, especially if the burn is greater than 10% of the body surface area. You also can have hemolysis that occurs, and that's you have destruction of the red blood cells. You can also have erythropoietin, that is reduced, production is reduced due to bone marrow suppression. And lastly, patients with extensive burns usually undergo a variety of surgical procedures which result in blood loss and which further exacerbates the anemia. How to calculate the expected blood loss. Again, the formulas vary, but please familiarize yourself with this slide. We're talking about inducing the patient. There is no single agent that is preferred for the induction. Again, ketamine is a good choice, especially in a hemodynamically unstable individual. So remember, you will need fluid resuscitation should be occurred, and you may have to decrease your dose during your resuscitation phase of your IV induction agents. Careful and slow titration of agents is essential. And again, benzos and opioids are appropriate pre-medications, especially when the patient has anxiety and pain. Regional considerations. Again, regional is usually used for procedures confined to small areas, such as an extremity, or for surgery during the reconstructive phase. In children, regional anesthesia is sometimes a viable option for post-op analgesia, and so caudal or epidural techniques have been used for debridement of the lower extremities or harvesting skin grafts. Catheters should extend the regional block for the post-operative infusion analgesia. Pain management. Again, opioids are an important adjunct in the care of burn patients. Also, non-steroidal anti-inflammatory agents can be effective analgesic for smaller superficial burns. During the reconstructive phase, the patient may experience many procedures, and they may have to have multiple skin grafts occur. Months to years after hospital discharge, again, many of these burn victims will return for these reconstructive procedures to remove or reduce scar formation. The most important anesthetic concern is the management of the airway, particularly if we have contractures of the neck or face may be present. Again, there may be options for airway management, as mentioned previously, from your standard laryngoscopy, such as awake intubation with fiber optic as necessary.